All right, good afternoon, everybody. Thank you for attending the Evoke Neuroscience Lunch and Learn today. I'm Morgan Ingmanson. I'm the Medical Affairs Manager here at Evoke, and we're super excited to be talking about therapeutic recommendations for memory loss today. And you guys are getting a break from me. We actually have a special guest speaker, Dr. Richard Isaacson, that's going to be walking us through the presentation today. But before we dive in, I want to make sure that everybody can hear me and see my screen. So if I can have you navigate to the question box on your GoToWebinar menu, there's a questions tab. And if you can just navigate there, write in, like, yes, I can hear you. Tell me how the weather is in whatever region of the country you're in. I'm in Northern California. It's 80 degrees and sunny. So loving the weather here. Getting some responses coming in, so that's great. Everybody can hear me, and we should be good to go. So today is going to be on therapeutic recommendations for memory loss, and just to kind of set the stage a bit, I want to kind of rehash this memory loss conundrum that we've talked about in a couple of our past Lunch and Learns. We're all familiar that upwards of 20% of those aged 65 and older already have detectable symptoms of MCI. But we know that diagnosing memory loss can be really challenging. There's this struggle of diagnosing too late or misdiagnosing or underdiagnosing. And we're pretty limited in the current approach, which uses effort-based screening measures, because alone these measures have relatively poor sensitivity. So things like the mini mental state exam, clock drawing test, and verbal fluency test, while they have great specificity for memory loss, they have poor sensitivity, especially in those early stages of memory loss before you reach that Alzheimer's stage. Now, the good news is there's kind of a more modern way of differential diagnosis. And we know that memory loss is a brain problem. And of course, we need to look at the brain to figure out what's going on. So we can kind of think of assessing memory loss in this trifecta of behavioral effort screeners, so MoCA and MMSE, and then the biochemical component, blood, saliva, genetic testing, and then brain electrophysiology, which is our way to look at the brain directly, assess brain function and brain health using things like EEG and ERPs. Now, you guys are Evoke Neuroscience customers, so you're familiar with EVOX, which is basically a memory loss biomarker test that facilitates you in aiding in diagnosis. We have talked a lot about our different biomarkers that does help in making a diagnosis of early memory loss. So things like cognitive capacity, that would be our peak alpha frequency that we've talked about from that resting state EEG. We've talked about brain processing speed and looking at our ERPs, specifically that P300B component of the ERP waveform. And then brain activity, looking at our resting state head maps. Do we see too much slowing in our slow frequencies? Do we see not enough fast brain frequency activity? And all of these things together are allowing us for early detection of memory loss. And that's great because we know that if we can do early detection, it gives us the opportunity for early intervention. Brain imaging testing can detect MCI indicators 15 years prior to symptom onset, which is great because you see it early, you can intervene early. And we know that memory loss patients can be readily treated if they're caught early, such as those caused by vitamin deficiencies, stress, cardiac contributors, etc. So the question that we often most receive at Evoke Neuroscience from our customers is, I have this great tool that helps me identify early memory loss, which is the EVOX system. But now that I've identified these patients that do have early memory loss, what am I supposed to do about it? How can I help these patients from advancing further down this memory loss path? And really, no speaker is better equipped to talk about preventing and treating patients with memory loss than Dr. Richard Isaacson. He's the director of Alzheimer's Prevention Clinic and the director of Neurology Residency Training Program at Weill Cornell Medicine and New York Presbyterian Hospital. He's a specialist in Alzheimer's disease risk reduction and treatment and mild cognitive impairment due to Alzheimer's and preclinical Alzheimer's. And he's also a fantastic author of 2 best-selling books, The Alzheimer's Prevention and Treatment Diet and The Alzheimer's Treatment and Alzheimer's Prevention of Patient and Family Guide. So he definitely knows his stuff. We're super thrilled to have him here with us today to give this presentation and finally be able to answer that question of, now that I've identified these patients with early memory loss, what course of action can I take to intervene early and have a positive outcome? So at this point, I'm going to hand it over to Dr. Isaacson, and he will take it away.
Okay, well, thanks so much. Morgan, can everyone hear me okay? I don't know where that chat box is to make sure everyone can hear me, but
I can certainly hear you. It looks like we have some comments coming in that, yes, we can hear you.
Okay, great. The weather in New York is freezing. I was at the Yankee game yesterday and my hands were frigid, and that's why when a ball came near me in the stands, I dropped it. But I did, even though I dropped it, I did pick it up off the floor. So yes, I officially somewhat caught a ball at the Yankee game yesterday, despite the freezing cold weather. Sorry, I digress. Thanks so much for having me, and nice to be here with a nice group of folks. And today I'm going to give you guys a broad brush overview of the therapeutic recommendations for memory loss, and try to untangle some of this evidence. Do I need to move this box on the right? Should I remove it off the screen, or could you guys not see that?
We can't see it. We can see your screen beautifully. Okay. And I just want to make a quick announcement for our audience that is attending live today. We're going to have a Q&A session after Dr. Isaacson finishes with his presentation. So if you have a question that pops up in your head as he's going through, just send it in to your question chat box, and we'll see if we can address it at the end of the presentation. Okay,
sounds great. So let's get started. So we'll let's see here. Here we go. There we go. So start off with some disclosures. I've been funded by a variety of sources, National Institutes of Health, help pay my student loans, which has been very helpful for me. A lot of student loan debt from med school and college and everything, funded by the NIA program project grant, an American Society of Neuroradiology grant, a lot of philanthropic support in the field of Alzheimer's prevention. There's just not well-defined funding mechanisms, so a majority of our support actually does come from philanthropy. I've served as a scientific consultant and advisor for Lilly, NeuroTrack, and 23andMe. I'm a trustee of the McKnight Brain Research Foundation that focuses on age-related cognitive decline and cognitive aging overall. But in terms of my disclosures, some people say, well, is this person biased? Do they have, why did this person think this way or that way? When it comes to my disclosures, my number one reason that I think differently when it comes to the field of brain health and Alzheimer's prevention and memory loss is because of my uncle Bob, my dad's cousin Charlotte. And what the heck do I mean by that? I mean by that, I have a family history of Alzheimer's disease. So when I do that, and I've seen various family members, now 4 family members actually develop the disease over the last 20 years since I was little, and in high school, I take a different approach. There's got to be something we can do, and as long as something's evidence-based and safe, I'm going to think about it as a therapeutic strategy. So we'll go through all of that today. In terms of the overview, I would love to give an overview about the memory loss evaluation and management strategies that we think about. We'll talk about the variety of clinical trials out there. There are a variety of trials. If your patient wants something, to do everything possible aside from just clinical management, there are clinical trials that we can think about now, which is exciting. We'll give an overview of how the Alzheimer's Prevention Clinic at Weill Cornell and New York Presbyterian works. I often get a lot of questions about that. We were the first in the United States. Now there's different, a variety of clinics throughout the United States, and a few that should be starting in the next year or so internationally. We'll review the empirical evidence, and then finally end by talking about patient education strategies, because depending on how long you have with patients, whether it's 15 minutes or 30 or 45 or an hour, none of that amount of time is enough to really educate patients about what is and what is not in our control when it comes to brain health and supporting memory loss and trying to do anything and everything we can. So what we've done is we've created free online educational coursework and content for the public out there that all people can watch and see and take, at their convenience. So we'll talk about that too. Okay, so going back to my family history, this is a picture back in May of 1946, and my cousin's bar mitzvah when he was 13 years old. And if you look at this picture, you see all my old family members from Russia. This is the Russian side of the family. And if you move it along, well, unbelievably, 4 people in this picture ended up developing Alzheimer's disease. Why do I talk about this? Well, I talk about this because Alzheimer's disease actually starts in the brain over 20 years before symptoms. Alzheimer's is by far the most common form of memory loss. And in this picture, this is my Uncle Bob, and my Uncle Bob in this picture is young. He's 31 years old. He's normal. He has nothing going on, no symptoms of memory loss, no pathology in the brain. But I wanted to walk you through some pictures in his life, because at some point even he may have normal memory, but the disease has started in his brain. This is the pre-symptomatic, preclinical phase of Alzheimer's specifically. And at age 45, you don't think of people with Alzheimer's, but he had it starting. Mild cognitive impairment, which is what we know, those senior moments, those early memory loss glitches, that's actually stage 2 of Alzheimer's. And then finally, when someone can no longer take care of themselves, that's Alzheimer's disease dementia. And that's when the brain shrinkage has happened and the person can, needs a lot of help. And this is traditionally the stage of Alzheimer's, stage 3, that most doctors think of when you think about Alzheimer's disease. But as we know, this is a multi-decade disease, and I think I'm speaking to a captive audience that understands this. We can intervene earlier, and hopefully today we'll talk about why and how. Talking about Alzheimer's statistics, we brushed on this earlier, but Alzheimer's is by far the most common form of memory loss. And if you look at the stats, if at age 85, 45% of people have Alzheimer's, that means the disease started in their brain at the age of 65 and over. And okay, that means we need to think about Alzheimer's a little bit earlier. But if you look at the age of 65, 10% of people have Alzheimer's. That disease started in their brain at the age of 45 or more. So when you think about preventative care and trying what can we do to intervene against memory loss before it happens, as opposed to even treating memory loss symptoms, we have to think this is a multi-decade disease that's along the same lines as most chronic diseases of aging. For example, heart disease and stroke. Someone just doesn't wake up one day and have a heart attack or stroke and the disease started that day. Well, no, most of the time the disease has crept up for decades silently until the person has something happen, and Alzheimer's is no different. And again, Alzheimer's is by far the most common form of memory loss. So let's talk about Alzheimer's for a little bit. Well, what can we do in terms of FDA-approved drugs? Currently, there's 4 FDA-approved drugs in the United States that are used. They have modest alleviation of symptoms. They're not miracle drugs. They don't prevent disease progression, but they do have a fair amount of evidence, and most people use them. And again, lower the dose, the less chance of side effects. You then can titrate up, and basically you can have consistent effects in domains of cognition and global assessment. So if you are finding that a person has memory loss due to mild, moderate, or severe Alzheimer's disease, then we have specific FDA-approved treatments, and let's talk about those in a little bit. But what about, are there FDA-approved treatments for MCI, which is mild cognitive impairment, or SCI, which is subjective cognitive impairment, or memory loss in general? Because memory loss in a lot of ways is kind of like a wastebasket term. Is it truly memory? Is it an attention problem? Is it executive function that's manifesting as memory? Is it a pseudo dementia? Does someone really have depression and they're not remembering things because they're not paying attention? So when we have these other terms, these non-Alzheimer's terms, are there any FDA-approved treatments? Well, the answer is no. But I think there's so much more to this story, because even though we may not have specific FDA-approved drugs for the indications of mild, moderate, and severe Alzheimer's disease, we can treat that. But what else can we do? We can absolutely take an evidence-based, structured approach to your patients with memory loss of a variety of causes, and let's go through some of the evidence now. So, as an update, this just really came out a couple of months ago, so you may not be aware, but the American Academy of Neurology finally, after literally more than a decade, updated the practice guidelines, the evidence-based practice guidelines on MCI, which is mild cognitive impairment. And these practice guidelines basically had a variety of statements, and we'll go through each one. The first one was that evaluating patients with MCI for modifiable risk factors, assessing for functional impairment, and assessing for and treating behavioral neuropsychiatric symptoms has level B evidence. So what does this mean? It means that if a person is diagnosed with mild cognitive impairment, and my definition of that would be, mild glitches in memory that are not significant enough to impact activities of daily living, so the person is still able to care for themselves, well, the practice guidelines state that we need to evaluate patients for what their modifiable risk factors are, assess for the functional impairment, and assess and also treat behavioral and neuropsychiatric symptoms. So this is different because, whether I was in medical school or in residency training, we didn't really have practice guidelines to say that we should look at modifiable risk factors, and we shouldn't. Back then there was nothing that was recommended to do. So the good news is that the evidence is coming around that these modifiable risk factors should be evaluated. We should talk about these things. We should discuss it with the patient, and then that way we can really have some sort of a pathway forward. Also, another level B recommendation was to monitor the cognitive status of patients with MCI over time. So when you make that diagnosis and you may do cognitive testing, it's a good idea to keep following that patient, because some people with MCI get better, some people stabilize, and other people continue to decline. And without really understanding their cognitive trajectory and without really doing serial cognitive assessments, it's not always clear not only how your treatment is working, but also how the person is progressing and what that person's MCI diagnosis may be. So MCI can be caused by a lot of things. If it's mild cognitive impairment due to, which is most significantly memory loss, short-term memory loss, the term there would be MCI amnestic, or mild cognitive impairment amnestic, and most of the time that will end up at a rate of 12 to 16% per year, end up being Alzheimer's disease later on. However, there's non-amnestic forms. Non-amnestic MCI may not be Alzheimer's disease. It may lead to a different sort of dementia, whether it's frontotemporal dementia or Lewy body dementia or pseudodementia of depression or a metabolic or vitamin deficiency, whatever it is. The key here is following cognitive status of patients over time can help really understand where the person may go. And if you know where the person is going to go in terms of a diagnostic shift, well, then you're going to understand how to best intervene. Another level B evidence is cognitively impairing medications for people with MCI should be discontinued where possible, and behavioral symptoms should be treated. So, I see tons of people that come in and they have memory loss, and what are they on? Well, they're taking a Tylenol PM or an Advil PM at night, and they think it's fine. And sure, it's fine to get to sleep, but the bad stuff in there, the diphenhydramine, which is commonly known as Benadryl, the diphenhydramine is not a great drug for a person to take, because you can have a hangover effect that can impair memory. A lot of people take benzos. Valium is very common. Klonopin, for example, Xanax even. These are great drugs to get a person to sleep, but are really bad drugs to maintain cognitive function in a reliable way. So these are definitely level B evidence, but something to think about. As we continue, clinicians may choose not to offer cholinesterase inhibitors, which is level B, and if offering, they must first discuss lack of evidence, which is level A. So as we talked about before, there are no FDA-approved drugs, meaning FDA-approved drug treatments for mild cognitive impairment. However, there have been a variety of studies, and occasionally the studies have a signal that are positive, other studies show a signal that are negative, and while there's no FDA approval, the recommendations state that clinicians may choose not to offer cholinesterase inhibitors. Okay, a little vague. But if offering, they must first discuss the lack of evidence. So what this all means is that sometimes we have to have an honest conversation with our patients and say, we don't have any FDA-approved drugs. However, some studies have shown one thing, other studies have shown the other. Let's discuss the risks and benefits. And then it's under really the clinician's judgment whether or not to prescribe these drugs in, of course, close collaboration and discussion. Of course, you have to document everything with the patient. The next MCI practice guideline, which we're excited to finally see these getting into the guidelines, recommending regular exercise. May sound simple. What's good for the heart is good for the brain. We've heard that, but exercise is much, much, much more, in my opinion. Exercise really has the strongest evidence possible for patients with memory loss, and especially in MCI, that the studies, while they're not perfect and we don't have, many years of randomized controlled trials, we do have, a fair degree of evidence that regular exercise is an evidence-based and effective intervention to mitigate the progression of MCI. Again, it's not a perfect thing, and we don't know the exact prescription and maybe which people need what, and we'll talk about that later. But overall, regular exercise, I recommend at least 150 minutes a week. However, they're now testing a variety of exercise doses and types. So Jeff Burns and colleagues recently got funding to look at different doses and different styles of of exercise. So for example, they'll be randomizing in 3 groups. This is out at the University of Kansas, just outside of Kansas City. And basically, they'll look at, is 150 minutes enough? Does it need to be 225? Does it need to be aerobic? Should it be more resistance training? Does it need to be more weights? Or maybe none of the exercise works. They're going to be doing a randomized trial to understand this. So we should know more in a few years. The next, which is level C evidence, a little lower, may recommend cognitive training. Now, cognitive training does have moderately strong evidence, more strong than other interventions for cognitive conditions such as cognitive aging. New Institutes of Medicine, or now they're called National Academies report, did find that cognitive training did have benefits when it comes to randomized studies. When it comes to MCI itself, the level of evidence is a little less strong, but you may recommend cognitive training. There's a variety of programs out there, and this is not necessarily recommending, say, Lumosity. The evidence there is pretty weak, but there are structured cognitive training programs that have actually been found, and there's a few out there that have more robust evidence than others. And the final MCI practice guideline is to discuss diagnosis, prognosis, long-term planning, and lack of effective medicine options, which is level B. And we may discuss biomarker research with patients as well, which is level C. So where these guidelines have gone is to take a pretty comprehensive approach to look at all the options out there and discuss with the patients that we don't have all the answers out there yet. We don't, know for sure maybe what you're going to get. But maybe we can discuss biomarkers, maybe we can discuss clinical trials, maybe we can discuss a variety of other options that may or may not have a robust evidence base. So again, good news that we're making progress and having practice guidelines out there, but still more consensus statements need to be formed, and that those should be coming in the next couple of years. So what if you do make a diagnosis, for example, of mild memory loss, of memory loss, and that is diagnosis due to mild to moderate Alzheimer's disease? Well, donepezil, galantamine, and rivastigmine are the classic FDA-approved drugs that would be started. And again, this would be for mild Alzheimer's disease, so memory loss that you do feel is due to Alzheimer's disease, whether it's due to cognitive testing, signature, it's a clinical diagnosis, progressive short-term memory loss, may or may not order a biomarker test. Donepezil 5 milligrams to start, slowly increasing, and taking that with food. Breakfast or lunch, whichever meal is larger, is always the suggestion I give to mitigate the GI side effects. Galantamine has an extended release, and you can titrate that slowly over time. And then rivastigmine patch, you start low and go slow at 4.6, then increase to 9.5 after a month if tolerated. The patch is maybe helpful because it bypasses the GI tract. It may give more smooth and continuous delivery, may be helpful for mitigating some of the side effects of an oral pill, but you have to educate on the rotating the patch and where to put it, and that sort of thing. Talk about some common barriers in care. So again, when it comes to Alzheimer's, which is the most common form of treated memory loss in the clinics, most people think that Alzheimer's disease is just Alzheimer's disease dementia, when symptoms are readily apparent and the person can no longer take care of themselves. But really, as we talked about earlier with my Uncle Bob, this is a disease that happens over decades, and it builds up over time. So it's really important that when your patients are kind of saying, oh, it's just a little bit of this, oh, it's just senior moments, oh, it's a little bit of that. No, I think clinicians and patients need to realize that we need to act and we need to do something probably earlier is better. And I think the earlier is better notion when it comes to intervention is something most of us can all agree upon. Let's then transition a little bit and talk about prevention clinical trials. So for example, if someone comes in either with very mild memory loss, very subjective complaints, mild, but does not meet the threshold, say, of mild cognitive impairment, or if someone doesn't have any complaints at all and the person wants to do a lot, they want to do everything they can. Well, the good news is there's prevention clinical trials. So if that person does have preclinical Alzheimer's or pre-symptomatic Alzheimer's where they have no or minimal symptoms. You can get in some of these trials with minimal symptoms, but they do have amyloid in their brain, then they can enroll in a variety of trials. One study, the A4 study, which was the first of its kind, actually closed last year, so we should have some results on that in the next year or two, more likely 2 years. The early trial is an oral drug called a BACE inhibitor, which is basically a beta secretase inhibitor. It slows down the accumulation of amyloid. This began late last year. Minimum age is 60 to enroll. The A4 study was 65, so it's good that we can get younger people in the pipeline. The generation 1 and 2 trials are recently, one was recently funded and one has recently just started. Generation 1 trial is only for people with 2 copies of the APOE4 gene, not super common, 1 to 2% of the population, but if you do know that someone has 2 copies of the APOE4 gene and they are at higher risk, there's actually a specific study just for them that's ongoing now. And then there's a new arm called Generation 2 trial where you have to have either 1 copy or 2 copies of the APOE4 gene, and now that'll be expanded. That'll begin later in 2018. So the good news here is there are clinical trials that are ongoing if someone does want that. If you do see somebody that is having a family history of early onset Alzheimer's where you're pretty sure or definitively know that they have an early onset gene, there are also early onset Alzheimer's prevention trials that are out there. So definitely be informed about that. Very, very rare. In our cohort, we have only a handful of patients with an early onset gene. Very, very rare. So now let's get back to some of the practical suggestions. So, and I wanted to use the framework of our Alzheimer's prevention clinic and kind of explain a little bit about how the program works and then show you how we apply the best available empirical evidence in a structured, evidence-based way to think about how we can intervene when a patient has memory loss. So when it comes to our methodology, we really have 3 key considerations. Number 1, anything we do should be evidence-based and safe. And of course, in a lot of ways, the gold standard of evidence is the randomized controlled trial, but also there's a variety of other ways to look at evidence, whether it's prospective data, whether it's epidemiologic data, keeping grounded in evidence, but also making sure that anything we do is safe is a really key consideration. Also, what we're finding, and really something we believe wholeheartedly, is that there is not a one-size-fits-all approach. If Mr. Jones comes in, he may need therapy A, B, and C. But Mrs. Smith, no, she's very different. She has different medical comorbidities, different genetics, different age, different gender. She may need therapies X, Y, and Z. So personalizing an intervention to the patient, really the concept of precision medicine is really where the field is going. And something we believe in. Finally, medicine is, and this field is not an algorithm, meaning there's no perfect recipe. So now what we're going to try to do is think about early detection, intervention, talk to patients about planning, all that kind of stuff. But really, what can we do? And here are some resources for your patients. The Alzheimer's Association has a nice handout. The NIA, National Institute of Aging, has a Keeping Your Brain Healthy as You Age link, and JAMA Patient Page came out last year, which is also a really nice review. So if you want to give some handouts, these are certainly helpful. When it comes to our visits, we spend a lot of time with patients. We do cognitive testing and labs and vitals and body composition, all this kind of stuff. So if you're interested in learning more, the link to our methods paper is on the screen. I'm not going to go into it at this point. I'm going to focus more on interventions, but this is really what we look at. We look at the A, B's, and C's of Alzheimer's prevention management, which is really the paradigm that we talk about. So how do you personalize a plan for treating memory loss or personalizing for risk reduction? Well, we look at body fat, we look at muscle mass, we look at blood biomarkers from lipids to inflammation, metabolism, nutrition, and genetics, and we look at cognitive function, and we take all of this together and integrate and triangulate the data and create a personalized plan for that person. For example, if someone has high body fat, Well, maybe they need more high intensity exercise. If someone has low muscle mass, well, maybe they need more strength training. So instead of just giving a specific prescription, we give a precision prescription. And that's one of the major concepts when it comes to the interventions we talk about. We look at risk factors. If you look on the right side of the slide, that's the modifiable risk factors, and that's where where we'll conclude by looking at all the different interventions out there: dietary interventions, physical exercise, cognitive engagement strategies, sleep patterns, musical activity, social engagement, and stress reduction. And then, of course, cardiovascular risk factor control, blood pressure management, tobacco cessation, cholesterol management, and diabetes. If you want to press the fast forward button on memory loss, don't control your cardiovascular risk factors. And we don't want that. We want to slam on the brakes. So we need to control cardiovascular risk factors. And those are really important concepts when it comes to the management of a person with memory loss. Also, when it comes to patient education, we only have X number of time, excuse me, in the clinic. So we've created a free website. This is actually a clinical trial. It's a research study to study the effects of education on patient outcomes. So if you want your patients to learn about the interventions that we're going to talk about in a couple of minutes, they can take a free online course. And this site has been visited by almost 800,000 people now over the last 4 years. We have really shown that people can learn by taking online coursework. Here's a variety of research studies that are ongoing in our program, and now I'm going to teach you and kind of give you an overview of the types of interventions that we're studying currently in our registry. The categories, again, are nutrition, physical exercise, cognitive activities, music interventions, stress reduction, social interaction, and education on that site that I talked about. So let's talk about nutrition. There's really been an exponential increase in the evidence when it comes to Alzheimer's disease, but also across the spectrum of MCI, cognitive decline in general, and even age-related memory loss. So the devil is in the details here. We're talking about therapeutic interventions for memory loss, but there's different reasons for it. This slide talks about the different references, and there's a variety of randomized controlled trials. For example, cocoflavanols was a study that was published several years ago, purified cocoflavanols, and that was in one population. Low carb, low saturated fat diet, that was in an MCI population. Very low carb diet or ketogenic diet, that was in a MCI population. Yerkomoro and colleagues looked at an age-related cognitive impairment group. So if you look at the variety of studies out there, it's a little complicated and a little confusing because all the different studies use different interventions for different groups of people. So that's what makes intervening in a memory loss patient different, because we need to try to hypothesize or figure out what that person's etiology is, and sometimes we don't know what it is because we don't have the best technology and we don't have the best diagnostic tests, so we have to use our clinical judgment. This is one of the science-y slides that kind of goes through why some of these interventions work. I'm not going to spend too much time on this, but there is a whole nother talk I can do on really the basic science principles behind this. We have a paper coming out in Frontiers of Aging Neuroscience. It should be on PubMed probably within a week or two, that really talks about this in great detail if you're interested. The nutritional interventions we'll talk about really fall into different categories. 1, dietary patterns, and then 2, single or multiple nutrients. And this is a major conceptual thing to frame because people have a different dietary pattern, but we also should focus on different nutrients that we may need to pay attention to in order to slow or support memory loss, depending on the person's etiology. So in terms of the best available evidence, a Mediterranean-style diet. I'm sure most of you guys are familiar with this. Mediterranean-style diet with plant-derived foods, olive oil is the primary source of fat, fish and lean poultry, red meat in low amounts, and wine in low to moderate amounts. This dietary pattern probably has the most evidence in delaying cognitive decline and possibly reducing risk for Alzheimer's disease specifically. Now, in a patient group of MCI patients, when people were randomized to 2 different groups, one, the typical Western diet versus a more brain healthy diet focusing on the extra virgin olive oil and the low glycemic carbohydrates and the lean proteins, which is much more Mediterranean style, in a randomized study in mild cognitive impairment patients with Suzanne Kraft and colleagues, who's really a giant in the field. In just 8 weeks of dietary overhaul using this dietary pattern, they were able to show significant improvements in memory. Again, just 8 weeks. So Can someone change their diet and change their brain? Well, yeah, I think we've shown this now in several different studies. Dr. Robert Krikorian, a close colleague of mine, did a really tremendous study several years ago looking at another group of MCI patients with dietary ketosis. Now, dietary ketosis isn't easy. This is very low carb. This is less than 60 grams or so of carbs a day. Lots of high fat, lots of high protein. This also resulted in just 6 weeks of improved memory performance, weight loss, better metabolic status, including fasting glucose and fasting insulin. So can dietary approaches work in a randomized trial in MCI? Absolutely, and we've seen this time and time again. When it comes to the MIND diet, this is one of those newer things. Now, it's never been tested in a randomized study. A new study called US Pointer will be getting going at a few sites later this year, but does a rigorous pattern of dietary change that's a little different than the Mediterranean style diet, but has a lot of overlap. Will this dietary pattern work? Well, it may, and a new randomized study will look at that. When it looked at risk reduction over time in a large prospective study, eating this way reduced risk of cognitive decline and Alzheimer's by 53%. Sorry, the reduced risk of dementia, by 53%. The finger study, you may have heard about the finger study, and now we're talking about not just including a dietary pattern, but adding in exercise, cognitive training, and constant monitoring by a clinician. This study was really revolutionary for the field, and it showed that multimodal interventions, including nutrition, multiple other lifestyle factors, and a group of people aged 60 to 77 actually had benefits. And what do I mean by benefits? Well, improving processing speed, improving executive function, and improving memory in complex memory tasks, but not significant improvements in overall memory. The other part about this finger study, which was just published, this is an ancillary analysis that was just published several months ago, that actually showed, this is in JAMA Neurology, I believe, that ApoE4 carriers and non-carriers both had beneficial effects of exercise, diet, and cognitive training. And this really is in line that shows that, genes may not be our destiny. We can win the tug of war against your genes. Using multimodal interventions works for all people with different genotypes. And in some studies that have shown that exercise actually has a greater effect on E4 carriers, again, genes are not our destiny. We can intervene, and this study was the largest randomized controlled study that looked at 1,200 patients over 2 years. So we really have quality data now. This other study, though, called the MAP study, this was a tricky because this study did not work. This study was negative, and why? This group of patients was similar but different to the finger study group. The patients were older. They were more frail, and maybe that's why this study didn't work. They also gave omega-3 fatty acids, but they didn't assess what the person's omega-3 levels were at the onset of the study. So maybe that one-size-fits-all approach didn't work. So again, even though we've talked about some studies that have shown some really amazing benefits, other studies out there have not shown benefits. So we need to really keep doing research and really understand why. Caloric restriction has been shown to actually reduce the likelihood of developing MCI, which in a Mayo Clinic study, that's a prospective study. Fish oil and omega-3s. We've heard a lot about fish oil, a lot about omega-3s. What is the difference? Well, the omega-3s are the fatty acids. Fish oil is kind of a misnomer. People get the fish oil from the fish, but the fish get the omega-3s from eating the algae. So there's been a variety of studies that have looked at both taking fish oil as well as taking the actual omega-3 from the algae itself. And one of these studies, Yurko Mora and colleagues, showed that having the algae-based omega-3 oil and age-related memory loss, age-related cognitive decline, really a construct of cognitive aging, that method of using omega-3s was beneficial in a randomized study. Other studies have not shown benefit. So the devil's in the details here. Things are a little bit confusing. I think where the field is going is when people have memory loss, maybe we should assess whether they have low omega-3s in the first place. And if they do, maybe we should supplement. Or, of course, though, eating fish, fatty fish specifically, lake trout, mackerel, herring, albacore, tuna, wild salmon, sardines. These are fish that are high in omega-3s, and we should always try to encourage eating fish with high omega-3s. And if that's not helpful, then maybe supplementing is helpful. And more studies need to be done here. There's also a variety of evidence on B vitamins. People with MCI that also had elevated homocysteine, those are the patients that benefited from B complex vitamins. What do I mean by that? I mean by precision medicine. If you put everybody on B vitamins, not everyone will respond. But the people with high homocysteines in the blood do respond. What do I mean by respond? Improved memory scores on the mini-mental, category fluency, and episodic memory, and also a slower rate of atrophy or brain shrinkage in the active treatment group. Again, people with high homocysteine with MCI should, in my opinion, based on the evidence, be on B complex vitamins, B12, folic acid, and B6. If they don't have high homocysteine, then there's no evidence to put people on B complex vitamins. Again, this is really the concept of precision medicine and not a one-size-fits-all approach. Wake up and smell the coffee. That means there's only a few minutes left in the talk, and then we'll have time for questions. Caffeinated coffee, are there great randomized studies? Well, no, but epidemiologic evidence does suggest that caffeinated coffee, especially earlier in the day, may have a protective effect on the brain. Flavonoids, strong evidence to support that regular blueberries and strawberries can delay cognitive decline, but does it improve memory loss? I don't know that we have the perfect evidence just yet, although Robert Krikorian is working on some really exciting stuff using blueberry powder, and a randomized study was recently published in that area. When it comes to dark cocoa powder, well, there is some evidence in terms of randomized studies, now several, that shows that regular intake of dark cocoa powder, the cocoa flavonols, purified cocoa flavonols, not only improve memory, but also blood pressure control and insulin resistance. So again, we do have options that are out there that are safe. So really where the field is going is, can we determine what the best brain healthy dietary and nutrition patterns are, and is there a one-size-fits-all approach? Definitely not. We need to figure out the map for who needs what. Really where the field is going is a direction of nutrigenomics and pharmacogenomics. One day we'll get genes, we'll get a better picture of what people need, and based on their genes and based on their individual biology, we'll be able to treat them in a more precise way. Physical exercise, I don't think we need to talk too much about this because I think we're all in agreement. What's a great way to help the brain? Well, more exercise, less brain amyloid, and that's been proven in mice, and it's been proven time and time again that exercise has a beneficial effect on the brain. Music activities, great way to actually improve brain function. Intensive musical training, even late in life, can help brain function, and this has been studied by a variety of labs, and actually I joined a rock band. We're called the Regenerates, Music for the Right Brain, and I believe that music is a great way to invigorate the brain and improve brain function. Stress is bad. Reducing stress is good. The last thing we want to do is make the brain age quicker. So stress reduction is something that we should all talk about with our patients. Social interaction. You can Google it, more Facebook friends, bigger brains. I'm not saying that Facebook is a memory loss treatment because there's no randomized studies, but what I can say is that keeping the brain engaged, keeping the brain active is a great way to support brain health over time, and there's a variety of evidence to support this. What we've done in our program, in our clinical program, this is the first pilot study we published where can patients who are either have normal cognition or mild memory loss, can we prescribe these types of multimodal interventions as we discussed today, and does it have an effect on memory? And what we're showing is yes, we do, or we are finding significant improvements from baseline to 6 months in processing speed, executive function, and while in this small study, memory function did not improve significantly, there was a trend. And I think our upcoming studies will do a much better job at clarifying this. Potential benefits for online education, I talked about that earlier. For all those people in busy clinical practices, if you don't have time to talk about this with your patients, we've created a site, and also there's a variety of sites out there. The Alzheimer's Association has a site, clinicaltrials.gov is a good site, and endallsnow.org is a great place to connect your patients to resources out there for clinical trials and otherwise. Alzheimer's Universe is the site that I talked about, and basically what we're finding is that when people want to learn about brain health and what they can do about it, what is and what is not in our control, we've used this site to educate the public. I'll end on this slide, but just real brief. There's introductory coursework for the public that you can suggest your patients watch. There's a caregiver course And there's also a healthcare provider course. So if you go to alzu.org, all for free, doctors out there can also learn. And soon the course will be CME accredited. Give us about 6 months for that. So with that, I think I'll end, and I want to leave appropriate time for questions. And thanks so much for letting me give you a review today.
Great. Thank you so much, Dr. Isaacson. That was very informative. A lot of exciting stuff coming out, especially with regard to the diet. I mean, as you said, the devil's in the detail, and it looks like so many of these studies are implementing different protocols. So from like a primary care physician point of view, what would you recommend as an early intervention? I mean, in the case where, no, not one size fits all, but if you don't have a ton of contact time with patients, is something like the Mediterranean diet the way to go, or caloric restriction, or the ketosis diet? I mean, do you have an opinion on that, of what you think would be the most effective approach?
Yeah, so good question. It's really hard to give this one size fits all approach, because you have to really get to know the patient. You have to know what they would be up for, what they would be resistant to. If you have to just give one general dietary approach, I think the Mediterranean style diet and making incremental changes over time is key. I do send a lot of people to this website. There's lessons about nutrition on there. They're basically trying to make every meal just a little bit more brain healthy. We give handouts to our patients, top 10 dietary recommendations. It really depends on the patient. A lot of patients don't mind adding blueberries and strawberries to their diet. A lot of people don't mind adding the dark cocoa powder as long as they like coffee. But in terms of the dietary patterns, it's tricky. Caloric restriction, most patients aren't going to be up for that. Some patients will, though, be okay with fasting, fasting from dinner to breakfast, maybe waiting for 12, 14 hours or more several nights a week. And that's a great way to at least get the ketones flowing a little bit in the morning. It may have brain protective properties, and also may help to restrict overall caloric intake if you're going to be not snacking at night. But putting someone on the ketogenic diet, very few patients, only a handful of my patients have decided to do that. So the goal really is to kind of get a sense of what you feel the patient may respond to best. Rome wasn't built in a day. You have to make your brain and belly happy. Someone that's been eating fast food 5 times a week, who has diabetes, isn't going to start eating Mediterranean tomorrow. So making incremental changes over time is probably the best gestalt decision I can suggest.
Yeah, that's fair. I mean, patient compliance, they're not going to be very obedient if you try and shock them into it right away.
Yep.
So kind of on the flip side of that question then, are there any components in the Western diet that really heavily contribute to the development of plaque in the brain? Are there kind of big hitters that people should be avoiding, that we should recommend for our patients to try and ease off of?
Well, if you want to fast forward amyloid plaque deposition, being insulin resistant is a great way to do that. And, our diet is very, very, very carb heavy. There's good carbs and bad carbs. Green leafy vegetables is really good and protective. Berries are good because they have fiber and they're low glycemic. They don't spike the blood sugar as much. But processed foods, white breads, white sugars, high fructose corn syrup, just really, people eat a lot of carbs and a lot of breads and a lot of pastas, and everything in moderation. But whole wheat is better than not whole wheat. But still, you can even have a whole wheat bowl of pasta that's really big, and it's going to spike your blood sugar, and it's going to be a whole load of carbs on you. So I think one of the best things a person can do to slow down that amyloid cascade, and this needs to be borne out and studied over time, is really reducing carbohydrate intake and focusing on the good carbs rather than the bad carbs.
Great. Okay, so we have a couple questions on specific supplements and different peptides. So one is, are you familiar with a peptide called cerebrolysin? And if so, what's your opinion on that?
Mm-hmm. So cerebrolysin is not on my recommendation list just yet, but I think there's some interesting kind of research going on about it. Most of the interventions that I kind of stick to are have a little bit more evidence in terms of you know, specific cognitive impairments like Alzheimer's disease specifically. Cerebral lysin is interesting because it really focuses on, for example, as one of the many pathways, BDNF, and BDNF is a really great, potential intervention because it's just like what gets benefited in exercise. So I guess the moral of the story is, while cerebral lysin is interesting, and there have been some studies, even with 10 years ago as well as others, and it also is generally well tolerated. I have not used it much in my practice, but I would say there is an evidence base for it, but I have not used it much in my practice. It's to me, it's been used more so maybe with vascular cognitive impairment, and I guess most of my focus has really been on Alzheimer's prevention specifically.
Great, that makes sense. Okay, we also got a question on if you have any favorite cognitive training programs that you specifically recommend. I mean, obviously we know that cognitive engagement activities does play a role and can play a role in Alzheimer's prevention. So are there any specific approaches that you found work particularly well?
So when it comes to brain training, there's a lot of ups and downs and backs and forths and controversy here. But I think the biggest, the most robust evidence is really it's called, well, it was developed by a company, I have nothing to disclose, but it's called Posit Science was the company. And there's a website called BrainHQ, and BrainHQ has on it a test called a brain training activity called the double decision test. And the double decision is a test where they've actually shown that people, it's basically a speed training test. And recent studies have come out that show that doing the speed training, that 10 years later, people that did the speed training for, I'm not sure if it was 6 weeks or 8 weeks or 12 weeks, I can't recall the exact length of the intervention, but people 10 years later actually had less car accidents, as one of the outcomes, for example. So I guess what I would say is BrainHQ probably has the most robust evidence base, and that's easy to access. I believe there's a cost to it. I'm not sure how much it is, but it's maybe, there's a cost per month. I don't think it's too prohibitive, but I would say BrainHQ probably has the best evidence. I think there are other programs out there, some with less, some with more evidence, but that's probably the most evidence-based that I'm aware of.
Great. So kind of along the same lines of this cognitive training, what's your opinion on neurofeedback in relation to mild and moderate cognitive decline?
I would say that I like neurofeedback for several reasons. Number one, it's safe. Number two, it makes sense. I think the other part about neurofeedback is, we don't have as many of the large, randomized studies, so it's a little bit harder to, judge for sure. I think the other part is there's different ways to go about the concept of neurofeedback. So I guess my take-home point is I'm not opposed to neurofeedback. I'm just not for sure which intervention types may be the most beneficial. Okay,
great. I think we have time for one more question. And let's see. So we got a question on, once we've diagnosed MCI or SCI and we've initiated an intervention, how often should the cognitive status be reevaluated? How much time should have elapsed between implementing that treatment intervention, hopefully one that's tailored specifically for the patient, and then how often should you be continuing to reevaluate this patient as you continue to see them?
Sure. So I don't know that there's a standard answer that I think the field has agreed upon, but what I would say is in my clinical experience and based on our program, we assess cognitive function every 6 months. And within the first 6 months, some people say, oh, that's too soon, you're never going to see any change. Absolutely not. From my best clinical impression and experience and from the preliminary data that we've published, 6 months is absolutely enough time to see improvements or stabilization at a minimum, but often improvements depending on the person, how compliant they are. in just 6 months. Now, different people with different genes may take longer to respond. We're just trying to tease that out now. Women respond a little bit more robustly in some of our preliminary evidence that we hopefully should be publishing later this year. And that's a whole nother discussion. Also, some of our cognitive measures may be more sensitive in women when we look at the gender differences, and this is unpublished data, but stuff that we're trying to tease out literally as we speak. In a year, I think we have a better understanding, I guess, of where a person's going to go in terms of their cognitive trajectory. But in our clinical practice, I would say 85 to 90% of people, we have them come back every 6 months. There is a subset of patients that are pretty low risk and pretty stable that after a year or so, we just may feel that they're pretty stable and low risk, and maybe you need to come back every year rather than every 6 months. So I don't think, again, here we go again, not a perfect one size fits all. But I do think that at a minimum, to begin every 6 months, and then maybe low risk people every year makes it a reasonable assessment timeline. Great.
Well, that's all the time we have for questions today, but I just want to thank you so much, Dr. Isaacson. This was a really great talk, very insightful. I learned a lot, and we appreciate your time being here with us. So with that, I think we can sign off for today. Thank you, everybody who attended live. Really appreciate your active engagement and all of your questions. And I hope everybody has a fantastic afternoon. Thanks for attending our Lunch and Learn webinar.
Great. Thanks so much, everybody.
Great. Thanks. Take care.
Sure.